Thanks very much, Bev. Right, I'd like to introduce you next to Dr Chaponda, who's a consultant in HIV medicine at the Royal.
Thank you for inviting me to talk. The aim of today is essentially to talk about how the data we get from JMU, how that has helped us and how it has helped us at the Royal locally as well in terms of changing policy. So first, I'll start with a quiz. I'm told that everyone here knows their data very well, and so this will be very straightforward and very quick. So can I just ask, except for my three partners in crime, where are you, Liz? There, except for that lot, how much HIV is there in the UK? Percentage, numbers, whatever, bingo, whatever you know or think you know. And again, where's Jane? Jane Harris, don't answer because you've sent me the data. That data comes from here. Go on, 10%? 90,000? 22,000. 22,000, I wish this was money. 60,000? Okay. Who is most at risk of getting HIV? Black ethnic minorities, men who have sex with men, intravenous drug users. This is the sort of data that we want to be able to plan at a public health level as well as at the hospital level. And I'll come to show you how that data, having that knowledge, changes our practice. How much HIV is there in Liverpool? Lots, little, none. Quite a lot. Is that you, Denny, there? Shush. You do a lot of work in this area. Quite a lot. How much is quite a lot? My quite a lot and your quite a lot are very different. 7% of Liverpool? It's quite a lot. That's not my forte. That's why I get JMU to send the data. 5,000 people? Yeah, 5,000? Any other numbers? I like whole numbers. So 5,000, going up, going down? 4,000? Okay, interesting. And more important to me as a doctor is the person who is there with me. How long can a person with HIV live for? How long is a long time? So if a patient comes to see me, I should say to them, near normal. And they'll say, what does near normal mean? 70 odd, you live to about 70. Okay. And I think that's what's really important about the data. It should inform not just statistics and planning, but it should also be able to inform at an individual level. What does this mean for the patient? And we get all this from the data that Jane has been sending from JMU to us. There's having no data leads to poor outcomes. So patients will present very late. They will present with end-stage disease. We don't like to use the word AIDS because people are fixated with the 80s and TV adverts about that. We prefer to use advanced HIV. We don't want patients presenting with advanced HIV and morbidity and mortality. And there's a cost. When people present very late, if we're not looking actively, people will present in very sick situations. They need to be in intensive care, and that will cost about £3,000 to £30,000 per day, depending on what infection or co-infection they may have. So there's a big real cost to late diagnosis, and also to the implication that you have to treat multiple comorbidities, and it means most likely that the outcome from that individual is not 70 years. That you're saying if they're presenting late, they're probably going to have 1 to 10 years, if that. So looking at the numbers in the UK, as of 2010, if you remember from last year, actually from World AIDS, there was a BBC program that looked at the numbers. It's about 100,000 in the UK 100,000 who are estimated to have HIV in the UK, of which 70,000 are diagnosed and 30,000 are not diagnosed. The diagnosed are actually a population that is well engaged in the UK, unlike in Europe and in North America. They're well engaged with treatment, they're doing well, they will live to 70, they're doing very well. I am interested in that 30,000 that we haven't diagnosed. That is the potential patients who, well, potential people who will infect others. They're also the potential who will have harm to themselves because of their decreased life expectancy. And as you mentioned, there are certain high-risk groups, although actually you're right, someone who said we should be thinking of everybody. And I'll show you how the data has changed that. So men who have sex with men, people born in Africa, and again, mainly reflecting the fact that of the 44 million with HIV, about 30 million are from sub-Saharan Africa. Can I just ask, why are there more women in the data with HIV than men? Okay, so they've come forward for testing. So you're saying that women are better at presenting than men? You're not allowed to answer that question, so don't put your hand up. Any other thoughts? I mean, it's a good thought. Antenatal screening?
Children and people with HIV.
Great. And that's, I'm glad to get this answer from this audience. You're clearly well informed and will answer that. Whereas if you were a bunch of medical students, everyone would say, oh, maybe the women are more promiscuous than the men, which is not the case. So actually it is that the women come forward, as in antenatal screening is great. In Liverpool, we were absolutely rubbish at antenatal screening, and now it's one of the best places in the UK at antenatal screening. And what we use in Liverpool is the opt-out. So you have to actually say, I don't want an HIV test. And that's because if we test the mothers who are HIV positive, put them on treatment, you prevent mother-to-child transmission. That's a huge impact on that baby. It's a huge impact on cost. So it's been the way forward, and that's why the numbers there are seemingly more. But we know that probably the pool of men undiagnosed heterosexual is much higher because of the reflection from those numbers. So there's been a call for action at a national level by BHIVA, British HIV Association, and BASH, and you can see what they all stand for at the bottom, to say, if your area is high prevalence, and they define that in a cost-effective manner, greater than 2 per 1,000, then you should be doing blanket testing. Anyone who walks in should be offered an HIV test and should be tested. It is not cost-effective if your prevalence is not greater than 2 per 1,000. You're probably testing most people who are low prevalence, and with all tests there's a false positivity, and that you're more likely to increase costs and increase anxiety rather than getting true positives. So, and this has been done on North American data, and that's how BHIVA, BASH, and BIS came across this this definition that we now use. So if you look at the UK overall in 2010, the areas where the prevalence was greater than 2 per 1,000, this was 54 local authorities, 29 were in London, 25 outside London, and 3 were in the northwest. And again, I have to thank Jane for giving me this data from JMU. So if we now look at the data that's generated from here, rather than from the HPA, looking at the northwest, if we look at where is that prevalence of greater than 2 per 1,000 in the northwest, and you'll find in Salford, in Manchester, about 5 per 1,000, Blackpool, these are high prevalence areas where in their acute medical units, for example, they've run pilots where they've done screening, where patients come in, you come in with a finger cuts, you come in with a cough, you come in with anything, and you will be offered an HIV test. In Liverpool, the prevalence is less than that. It's less than that 2 per 1,000. So we can't use the national recommended policy. So this is the data that we get from JMU, and this is very useful, especially to someone who's very busy, who can't go down to all the numbers and the graphs. I like to have this, is how the data was sent to me, in a graphic sense, where I can look and say, oh, these are the hotspots where it's greater than 2 per 1,000. That's the Royal Liverpool Hospital where I work. around that, the prevalence is not as high, which is why we're seeing overall in Liverpool 1.7, less than this area, which actually around the Royal is greater than 2 per thousand. So already it's informing me that, well, maybe I shouldn't be looking at Liverpool as 1.7. I should be looking at what is around my current practice. So where have we gone with this? Just to tell you again more about the data that we've got from Liverpool. So we know that there are 555 people engaging with services and living with HIV in Liverpool, of which in 2012, 54 were new to the service. New means newly diagnosed by our community team, newly diagnosed in the hospitals. Some may have been referred in from other centres. So for example, people who've moved from London and have come to live in Liverpool. Interesting, 60% were heterosexual and 35% were infected through men who have sex with men. So again, remembering the graph that I was showing you about the prevalence, the rates, and what people have thought, the infections we're seeing are in our heterosexual populations, which is what normally I wouldn't have thought that. 51% of these cases were white ethnicity and 44% were black ethnicity. Already that tells us that when we have these high-risk groups, we should forget all that, because then you marginalize, and the undiagnosed, the ones who are going to die, the ones who you're not treating fairly, are actually your heterosexual white population. So what BHIVA says is that in areas where your prevalence is less than 2 per 1,000, you must do indicator conditions, and I'll talk about indicator conditions. So what we've done with the data that we've received so far is we've looked at it at a local level and in 3 areas. So I sit on the Public Health and Public Health England board, and also the late diagnosis, and again Jane sits on that, where this data has been presented, and then we've thought about it and thought we need to have some sort of action. We've got the data, we need to translate this into action. And the second thing is we've approached GPs in those areas, high-risk areas. We've written to all the GPs to say, actually, HIV is prevalent in Liverpool, like it is elsewhere. Think about it. And actually, in your area, look at the numbers. This is what it means in relation to this. So indicator conditions is where we say, we're not going to test everyone, but if there's a problem at a medical level, and I'm sorry if some of this is very medical, but that's fine, I can rush through that. If someone walks in with PCP, most doctors will know what it is. But if someone comes in with a subtle signs like pneumonia, no one would think, well, that might just be early HIV. We want it picked up as early HIV. So we're telling doctors, look for patients who present with early disease, like oral thrush, like oral candida, patients who present with Kaposi sarcoma. We hardly see that. We don't see late presentation to that extent in the UK. But early presentation, patients who come in with shingles, highlighting to doctors, so I've presented this in grand rounds to medical students, nursing students, all levels of the healthcare, to say, actually, when you see an indicator condition, you must be testing. Hematological diseases, things that one wouldn't think about, leukemia, lymphoma, low platelets, all these could be the early signs, early indicators. So coming back again to what has the data taught us? So we've said HIV testing should be offered, and this is from that little book, should be offered to patients with known risk factors, men who have sex with men, intravenous drug users, people from sub-Saharan Africa. Well, actually, that's not what the data is telling us. The data is telling us that actually the newer diagnoses are in your heterosexuals, in your white ethnicity, patients that ordinarily we wouldn't be thinking about. And so we've been raising GP awareness in this and saying to them that actually we should be offering more testing. This is an actor, but it could be a patient. So it doesn't have to be the formal consent. So in the past, one of the barriers to testing was doctors, because it was so annoying to sit there and spend 20 minutes talking to a patient, having them to sign their consent, when it would be very easy to just say, look, you've come in with a cough, we routinely check for HIV, it could be HIV, can we test? Surprisingly, most people say, yeah, that's fine, go ahead. And because of that, there's been a change in national consenting to say, have a verbal discussion like you would any other test, and you'll find that people are very welcoming to that. There are potential hurdles. Some people will say, I'm not ready to have the test today, or I don't need the AIDS test, or if I got it, I don't want to know. What about my life insurance? I won't be able to get insurance. Or I get all sorts. I'm not gay, therefore I don't need it. It's understanding what people think, understanding their reasons. And some of it, most of it, is actually trying to change the mindset to say, actually, what you understand is probably wrong. We don't say it's the AIDS test, actually, because people live and they do well on treatment, and understanding that most of it is their fear, that actually there are no penalties. For having an HIV test, insurance companies will now not give you a penalty for that. Most important is understanding that we've come a very long way. When I started practicing medicine, HIV care was very much palliative care, helping patients to die. But actually we have moved way over. We've moved over to single tablet regimens, so a patient starting treatment now can expect to start 1 tablet once a day. And I say to them, which is what I think patients would like to hear, certainly what I would like to hear. If someone says, how long will I live? I'll say, you live long enough to see your grandchildren. And that's a big thing for patients, because they think, so you're saying to me I can have children and grandchildren? And you can say, yes, you can have children who will be born HIV negative because of treatment, and you will live long to see your grandchildren. So it has real meaning for patients. So we say to patients who are newly diagnosed, it's a lifetime, that you will be with us along the way. We may have to change your treatment because of toxicity, etc., but they're newer, cleaner drugs. I think more important, the data that we've got, and this is recent data that we've got from John Moores, to say, actually your prevalence has changed in Liverpool. And we've used this to go back to the chief exec to say, you know that thing that we've been talking about, indicator conditions, and saying let's target people who we think may have HIV, we might be getting it wrong. I think the policy that we should be looking at is blanket testing. And actually in places where you do that, people find it acceptable. You're approaching everyone, you're not individualizing it. And so this is something that we're taking forward. Certainly in the late diagnosis group, all the GPs are now being told, actually think about HIV in all your patients. And there's been a big switch, and you will see, if any of you are unfortunate enough to need to go to the hospital, you will find that you will be offered that routinely, and I think that is right, rather than saying, let's target risk groups, because if we do that, we get it wrong. And the data shows us that we're getting it wrong in terms of the prevalence. I'll stop there, if that's all right. Thank you.